Hello, can we reconvene the
little
meeting,
clicker?
please?
Oh, here it is.
Okay, welcome back, and I hope you all had a chance to refresh and recharge. Next up is our final health care session to look at evolving business models aimed at controlling costs and improving patient outcomes. Dr. Donaldson, please introduce your panel.
Thank you, President Jones. This afternoon's panel explores how to re-stimulate healthcare competition in the ever-changing California market. Our agenda today will look at managed competition. We'll rethink about what is happening in California's economic markets today. We'll look at competition from the perspective of the medical group and the hospital as well. We haven't not heard from our providers in some time, so it's nice to have them with us. I'm Kathy Donaldson. I will make some opening remarks on the CalPERS competition model, and then I will turn the actual remainder of the program to Dr. Robinson, who will assist. Actually, he will lead the moderation of this panel. California's healthcare markets are changing, as evidenced by accountable care organizations, provider consolidation, health plan and provider mergers, reemergence of regional health plans, and different healthcare payment structures in the form of plan and provider shared risk arrangements. CalPERS has 7 HMO carriers and 9 health plans. We have 3 self-funded PPO plans, a pharmacy benefit management company, and 3 association plans. From 2004 to 2013, CalPERS contracted with 2 HMO plans, the Blue Shield Plan of California and Kaiser, and for a short period during that time, Western Health Advantage. In 2014, after an exhaustive review of the market and the formulation of long-term cost containment strategies, CalPERS solicited 5-year contracts for more HMOs and rebid the self-funded PPO third-party administrator. Our strategy at that time was to stimulate CalPERS health plan competition, consolidate HMO pharmacy benefits, and partially self-fund our newly selected HMOs. We simultaneously rebid the PPO 5-year contract. I'm not going to spend a lot of time on this chart, but this does show our progress over the last 10 years. I have mapped, or our team has mapped, our aggregate premium changes against the membership growth, and we grew from 1.3 million lives in 2009 to nearly 1.5 million lives in 2019. Over that time, our premium increases ranged from about 3 to 7%. Positive contributors for the declining trend over that period of time included the ACA Early Retiree Reinsurance Program, which gained us $130 million to use towards early retiree health benefits. We added our HMOs. We implemented Medicare Part D, Medicare Advantage plans for pharmacy. We also implemented the Medicare Part D employer group waiver plan. At that same time, we also closed the net value plan. And we introduced the CalPERS value-based insurance design plan in 2019. Under the HMO flex funding, CalPERS collects the HMO premiums, pays the capitation, and administrative service fees to our HMO plans. And then we provide the fee-for-service claims to the state controller's office for claims payment. The flex funding allowed us full transparency on what is built into our premiums and allowed us the opportunity then to make sure that our premiums were consistent with the benefits we were providing. As you can see from this chart, we've mapped the CPI, Consumer Price Index, which is held steady at about 3%, and that in the last 3 years, 2017 to 2019, our premiums went from under 3% down to a little more than 1%. Now, I tell you this because I want to talk about where, again, you've seen this map, but where are concentration of our health maintenance organizations? They're found throughout California, and there's much overlap in many of the urban and suburban markets. The PPO coverage, again, where HMOs are not, are found in the white sections of this map. Now, there are many thoughts about competition, and that's why I've assembled 2 economists and 2 providers so that they can provide their perspective on the CalPERS model. CalPERS looked at, in the last 3 years, 3 different dimensions associated with competition. We looked at health plan competition, that is more plans competing against each other. We also looked at provider competition, that is more plans brought in more networks that were going to overlap with each other so that our members had not just a range of plans but also a range of providers. And then we looked at our payment models. That is, in each plan, how much plan premium had fee-for-service and capitation in terms of shared, dual, and global risk, as well as some of our plans that have global budgets, such as Kaiser and Sharp. So as we looked at how we added HMOs, if they wanted to be part of the CalPERS portfolio, we looked at improvements in geographic reach, that is expansion of coverage areas beyond each year if we could. We looked at the mix of capitation and fee-for-service, and we found through flex funding that the more capitation, the more predictable are the premiums in terms of forecasting. And we also found that we negotiated 5 years of third-party administrator fees, so we could budget in our contracts and with the Department of Finance, we could budget how much fee-for-service, capitation, and administrative services fees we were going to be projecting. Over 10 years, CalPERS team has systematically worked to contain our premium growth, as we've shown in the chart. And in the last 5 years, we used these competitive strategies I just described to bring us down to a 1.16% premium increase in 2019. So that was our model, but as I said, we've assembled these experts of economists and providers so that they can talk about their views of what California competition means and how are we viewing it today. To my left is a very distinguished professor he's Professor Emeritus from Stanford. He has over 50 years in healthcare, and he has been contributing to California research in both health and business for the last 60 years. And that's Dr. Alan Enthoven. He is the father of managed competition, and any student who went through healthcare in the 70s or 80s clearly understand what his name means and what he has provided to the state of California. We also have economist James Robinson, who has evaluated many of our innovative initiatives, but Dr. Robinson also has research topics ranging from emerging technologies in healthcare to reference pricing, both in the US and European markets. We'll also hear from our provider community, Kelly Robeson, who is the CEO of Brown & Toland. And then we'll also hear from Dr. Barry Arbuckle, who's the CEO of Memorial Care. After Dr. Enthoven speaks, I will turn it over to Dr. Robinson, who will manage the rest of this panel and questions. Thank you, Dr. Enthoven.
Thank you very much, Kathy. It's a real privilege for me to be here.
It's the little voice.
Sorry, okay. I'm really happy to be here. I've been writing about and studying managed competition for a long time, and I'm sure it's the case that CalPERS and Covered California are the best living examples of managed competition. You can be happy or comfortable that your management is doing a very good job in a difficult world. California's main health expenditures problems, I think, are too much of the overall market remains in open-ended, uncoordinated fee-for-service, which drives up costs generally. Kaiser Permanente wannabes are mostly not very effective. In addition, the federal and state governments, through the tax laws and Medicare and Medicaid, provide powerful incentives to spend more money. Whatever you do, if you make a decision that costs more, the federal government will be in there subsidizing it with tax relief or with direct payments through Medicare. A free market in health insurance produces bad results and just cannot work. You know, if you have a free market, then they confuse the customers, they try to select risks. And so the market must be structured or managed according to these principles. Individual cost-conscious choice of plan, reference pricing, that is that the employer or sponsor pays for the low-price plan, the employee who chooses a more costly one pays the difference. That's what we have at the University of California and Stanford. Neutral broker and a level playing field. Standard coverage contracts to facilitate comparison, prevent risk selection and segmentation, and focus competition on quality and price. And price competition on annual dues for comprehensive care. That's something that people can understand and act on, and quality-related information for consumers. So why competition? Well, people migrate to what they see as the best value for money. Different people have different preferences, live in different places, and so a range of choices is good. The National Academy of Medicine estimates that about 30% of healthcare spending is waste, that is, doesn't do anything to help the health of the patients. Competition drives systems to innovate and squeeze out waste. The government just cannot order efficiency improvement. I know because I served as Assistant Secretary of Defense in charge of bringing cost effectiveness to the Pentagon. It was a very quixotic task for a young man. So it takes systems to improve quality and economy. Desirable characteristics of integrated delivery systems include a proactive focus on the health of the enrolled populations, aligned incentives, so what's good for providers is good for patients and taxpayers, full sharing of information among providers caring for a patient, a culture of teamwork and shared responsibility for patients, a commitment to help develop and apply best practice guidelines, and strong available primary care to solve minor problems and to coordinate care. We talked some about HMOs. They're really two very different beasts that live under the title HMOs. There are delivery system HMOs and carrier HMOs. If you're going to say, where is an HMO, and it's a carrier HMO, well, you go to an insurance company. If you say, I want to see a delivery system HMO, or I'm looking for it, what you find is the Permanente Medical Group or some other medical group. Carrier HMOs are mainly fee-for-service, and fee-for-service, as we all know, rewards doctors for working harder, doing more and more costly services, pleasing patients, but also increasing costs at a time when healthcare is costing too much. The CEO of Kaiser Health System reported to me once that 10% of their workforce is occupied in preparing, sending, and collecting bills. It's very expensive fee-for-service. In the delivery system HMO, you have a medical group that takes responsibility for managing care. In California, carrier HMOs are losing market share to PPOs and are not much better than PPOs. In fact, PPOs have advantages such as less restriction in patient choice of doctor and compatibility with self-insurance. Delivery system HMOs, mainly Kaiser Permanente, rely on selecting physicians and group culture for commitment to efficient practice in patient care. The fee-for-service connection needs to be broken or phased out in order to get incentives aligned, and this will not be easy. Kaiser Permanente in California needs and now does not have an effective competitor. Kaiser people have written and published many explanations of what they do and how they do it, so it's no secret. Strength in primary care is a key to their whole story. An important objective for CalPERS is to encourage the development of at least one or two systems that can provide serious competition to Kaiser and to each other to produce value for money. Davey.
Thank you. And I also want to say what a privilege it is to join you today and be on the same panel as Alan and to work with the staff and the board, because CalPERS is a very large purchaser, but I've always felt that it punches above its weight in terms of influencing public policy and the private marketplace in California. And that's because it and you are willing to try new things, take risks, reevaluate your strategy. So it's really a privilege for me personally to be able to work with Kathy and Liana, and then really it's the board with President Hugh Jones and the rest of you that make this all happen. So what I want to do in sharing some time with you, is to go in the right direction rather than the wrong direction. Speaking with Kathy about the concept of re-stimulating competition. California is by far, of course, that's the home base of the concept of improving the quality and efficiency of care through the use of competition, market forces, consumer choice, et cetera. I'm sitting right next to the theoretician of that. And on my side, the other side, provider organizations that have embraced that vision. So we are ground central for that. But I think that it's fair to say that there's been doubts that have really crept in. It doesn't seem to be delivering on the hopes to the extent that we have all hoped. And I'm going to use the royal we here, assuming that we all agree, which of course we don't. But I think there's sort of a general assumption in a lot of California health policy and in CalPERS that the market-oriented competitive model is generally the way to go. So I want to these are our beliefs. We long have believed in market incentives to improve the efficiency and quality of care. But the market has evolved in ways that are not always consistent with those beliefs, and we are bewildered. Alan just laid it out. Why don't we have more things that look somewhat like Kaiser, that can give Kaiser a real run for its money and more good choices for consumers? We've got some, but we should have more. And we can't keep doing what we have been doing, or we'll keep getting the results that we have been getting. I mean, that's sort of a fundamental thing. And so market's changing, our strategy needs to change. So I'm going to just talk briefly about what I think are our beliefs, what we observe, and what our worries are. So our beliefs, I do 3 buckets each time. Managed care, the belief in managed competition. Integrated provider networks deliver cheaper and better care than broad choice networks, and generally we favor the HMO product over the PPO product for that reason. That's been a broad consensus. Secondly, on the provider side, the cottage industry of small practice and independent hospital has been inefficient. Physicians, hospitals, and other caregivers should integrate and coordinate their care. It's a fundamental belief that I think most of us share. Thirdly, on payment, fee-for-service rewards volume over value and imposes 100% tax on provider cost reduction. The solution is some form of capitation, and historically we thought more is better, global capitation. No, those are the things that sort of, to me, summarize where we've been. What do we observe, though, in the market? On the managed care side, on the insurance side, HMOs, with the exception of Kaiser, have been losing commercial market share to PPOs. Private employers are largely shifting to broad network, high-deductible health plans. Why? Why? This just seems like that was completely against what we believed the market was doing. Secondly, on the provider side, many integrated providers are using their large market shares to raise prices and to channel patients from low-priced to high-priced sites of care, from independent, community-based into hospital-based or other tertiary kind of centers where the payment rates are higher, the specialty dominated, exactly the opposite of what managed competition thought was going to happen. Thirdly, on payment, we now have all these ACOs and shared savings contracts. They're spreading, but honest truth is they're spreading rather slowly, and the cost savings to date have been, I think the word modest is appropriate, okay? It's in the low single digits, all the studies on that, all right? So how is it possible? We're pretty much at almost 50 years into managed competition. So the Califano regime, we're about 50 years into this, and this is our situation. All right, we're bewildered. So what do we do? On the managed care side, what do you do? What should our attitude be toward on the managed care side? Should we favor or fight against mergers of health plans and health plan PBM mergers, which we've been seeing? What do we think about small provider-sponsored health plans? There was a time when that was very much embraced. Then there was a time when people, like including CalPERS, moved away from them. Now they're back somewhat on the table. More than that or less than that? On the provider side, should policy and purchasers fight physician and hospital consolidation via antitrust and regulatory obstacles to consolidation? Or should we find a way to make integrated delivery systems deliver on the vision of managed care? And how would we do that? How would we do that? And on the payment side, is capitation, instead of giving incentive for cost effectiveness, is it actually cementing in the dominance of the dominant providers in each market who then raise their prices? There's no rule that says that capitation has to be low capitation. We can have high capitation. Just like there's no rule that says fee-for-service has to be high fee-for-service, we can have low fee-for-service. So what do we do with all these things that seemed to be settled topics are not settled? And then, of course, the markets differ. Southern California, very large, very competitive, with relatively low prices. Everything, it's just relative. Trend those towards consolidation from a purchaser perspective, worrisome. Okay? Northern California, it's already consolidated, prices already high, worrisome. Rural California, inadequate provider supply, local monopolies, worrisome. See, the word worrisome comes up 3 times in 3 buttons, okay? The trend, I want to give you and Kathy and her staff full credit for giving premium price increases at or below CPI in the last few years. I mean, that is almost a never before seen in the history of health care before, so congratulations. Nevertheless, the trends with consolidation is like worrisome. So we have these 2 terms. Consolidation, that doesn't sound good. Integration, coordination, that sounds good. How do we do with both of those? Okay, so what should we be done? So, and I'm just going to throw out the questions, and because I want your questions. With managed care, how many health plans should we contract with? Just a few and concentrate the membership, or many? What variety, what types of health plans? You want a real variety, or you want to really focus on those that you think are the most effective? And how can, I think collaboration with other public purchasers is for sure. On provider payment side, blended payment. Most providers still receive some fee-for-service. How can fee-for-service be made more value-based? There's a lot of blended models emerging out there. They're somewhat complex, but they have a fee-for-service, and then they have a capitation element in them. And then on the capitation side, my view of capitation is it works well when it works well, and it works really poorly when it works really poorly. You cannot capitate a provider organization that doesn't have the internal capabilities, information capabilities, care management capabilities, culture of collaboration internally. You give a traditional delivery system capitation, and it will just either throw it back at you or just collapse. And we have seen examples of that. So capitation is, and then on benefit design, and this is what most directly under the control of a purchaser such as CalPERS, I think the basic principle is that consumers should face financial responsibility for products and services where they have meaningful choices. But their choices need to be supported by purchasers who make meaningful choices available to them, and that is to offer a low-price option, eliminate low-value options altogether, mandate transparency, et cetera. And CalPERS has been a leader in both of those on the PPO side with reference pricing, and on the overall side with its defined contribution and managed competition. So it's You all have been and continue to be the market leader, but among purchasers, but the market is changing, and it is a time of trying to think about where the world is going, particularly in the world. How do you deal with increasingly consolidated, integrated delivery systems? How can you make those things not embrace providing good care regardless of the cost, but good care at an affordable, accessible, sustainable cost? That's your mandate. So I'm going to pass this over to Kelly, who's actually got a, you want to use that one? Okay.
Great. Thank you. Good afternoon. It's a pleasure to be here. This is my first time attending a CalPERS board meeting. Brown & Tolan Physicians has actually been, we just celebrated our 25th anniversary this past year. We have actually been serving CalPERS members for many, many years, thousands of patients. You're a really important employer group to us, and I'm really excited to be here. When Kathy reached out to us to ask to speak on this panel today, I was excited because as healthcare is transforming, Brown & Tolan and the entire physician model of care is truly in a state of major transformation around the country. And there's a lot that we're doing to really be ready for the future and how we think that we can be a better partner to our health plan partners as well as employers as we continue to serve physicians throughout the Bay Area. So a little bit about Brown & Tolan for those of you who may not be familiar. We are an independent physician association, an IPA. We have about 2,600 physicians throughout the Bay Area. We cover 6 counties and are on our way to covering 10. We are owned and led by physicians. So we are one of the few remaining independent associations in the state where physicians are not employed by, owned by, or controlled by hospitals or Kaiser. To many of the wonderful points that have been made in here in the session so far, I particularly like the comment, don't like it, but agree with the comment that there really isn't an effective competitor to Kaiser these days. There was a time in Brown & Tolan's history, back about 10, 12 years ago, where we actually had more HMO patients in our market than Kaiser did. And they're eating us for lunch right now. And the reason why, and what I'm going to focus on in this presentation to share with you, what is the physician's role in transformation of healthcare, and what are we doing about it? And the fundamental difference really is that physicians are struggling. If you look at some of the market trends going on, there already has been so much consolidation in healthcare, not only health plans and hospital systems, but provider groups as well. I spent 18 years at Brown & Tolan in the past. I actually helped build it. I left for 5 years and was with OptumCare, which is the very large entity, subsidiary of United Health Group, where we were buying and growing and building medical groups and IPAs around the entire country. And when I was there, we went from 10 markets to 32 in 4 years. It was a $10 billion organization just on physicians. The consolidation is staggering. And the impact to that on physicians as the Affordable Care Act has come out, as everybody, employers, health plans, everybody is struggling with the cost of care. If you take that down and really think about the healthcare system, who's the smallest? It's that individual physician. They're the smallest player when you really look at that. And so the impact on physicians has been pretty significant, to the point where earlier in my career, when you looked at physicians and assumed that physicians were making so much money and doing so well, it's actually amazing now to see how much that has changed, that we have many, many physicians literally struggling to keep their practices afloat. The pressures to take more risk have increased, the payment has decreased, and while, of course, throughout the years, much of that has been necessary, we're at a breaking point in terms of individual physician practices. So as a physician organization, where that's what we're here for, that's the question to us, is how do we transform the model in which physicians provide care to patients to where the physician can survive and thrive, and we can also provide the quality and affordability to our health plans and employers that they're looking for. And so we're excited about a lot of the things that we've been doing through the years and are now taking to a next level to really be a good partner and to make sure that physicians can actually survive through this tumultuous healthcare change. When we look at the landscape and how that specifically impacts physicians, one area is the market consolidation itself. There's payment issues. There's also interoperability. How do physicians manage all these complex systems? Where do we go from here? So from a Brown and Toland standpoint, we've actually, luckily, because we've been in this business for so long, and to Jamie's point earlier about the infrastructure that it takes in order to manage patient care, and Barry does this as well. As a physician organization with HMO, PPO, ACO, and Medi-Cal, we literally serve patients in every single product out there, and we have the infrastructure in place to manage that. We effectively run exactly like a health plan. We do all of the care management, utilization management. We process the claims. We do everything a health plan does except for sales and underwriting. So that means that we're actually agile. And as employers and health plans are looking at different ways of delivering care, we can actually flex with that. It's our same physicians, but as health plans are creating different products to remain competitive, as employers are even looking to become self-insured, we've actually already entered that realm. In fact, with Stanford being a really good example, where now you're looking at provider groups being able to participate in self-insured and bring some of those benefits that we're all aware of in California. We take for granted managed care and HMO. This is where it was born. You go around the country, people don't, the healthcare industry doesn't even really understand it. So when you think about the fact that we know how to do that, the way I look at it is, while there's a lot of burdens in the HMO product that patients and people don't really like, you can achieve some of those things through other products. Now you're starting to see, I laughed when I went around the country, you would see that markets that had HMOs, everybody's trying to make the HMO feel more like a PPO, but it really is still an HMO. Then you go to markets where they don't have HMOs, they have PPOs, and they're calling it a PPO, but they've put so many restrictions in it that it's actually functioning like an HMO. So you're finding this, the balance is, where do you find the benefits of that HMO managed care product that brings the quality and the outcomes that we see on a physician-friendly, a patient-friendly, user-friendly model of care that people really view the PPO as providing. And I think that's why we see so many of these middle ground products now in the ACO realm is, how do we get the best of both worlds? And from a physician standpoint, as there are more, or as an organized physician group, we can't expect an individual physician or a practice of 5 or 10 physicians to be able to take on the amount of risk that's expected these days. So having a larger provider organization like a Brown and Toland or a Memorial to be able to help manage that and carry that risk up at a higher level than the individual practices, but not so high level that it's the health plan making decisions that don't necessarily make sense, and they're just a little bit further away from the patient care. So really protecting physicians and employers and health plans to make sure that those payment methodologies work in a way that the physicians can handle it, the organizations won't go under, and that we can actually pull those quality outcomes that everyone is looking for. So what is our path? One of the things that we look at now with Brown and Toland, 2,600 physicians, but you look at where physicians are going now. When physicians are finishing up that residency program and deciding where to practice, there's a reason why they're going to Kaiser and to a lot of the hospital systems. The way physicians want to practice is very different now. It's technology driven. The EHR plays a critical role. These days, 90% of medical school graduates or residency graduates, by the time they finish, they've already worked on Epic. 90%. It's a very technology driven industry now. Kaiser offers an employed model with work-life balance, where you can actually, work set hours. Everything's taken care of. You only have to worry about one insurance product and not, whether something's covered or not. The frustrations that the physicians feel and have to deal with in their practice on a daily basis are really taken care of, and that's become more and more attractive to physicians coming out of medical school. That entrepreneurial wanting to come out, hang up a shingle, and have their own, independent or, be their own employer is less and less attractive to physicians coming out of school. So what we look at is there are a lot of physicians who they love the practice of medicine. They like that they consider themselves their own boss, that the patient is their boss. So I can't tell you how many of our physicians say that. I don't work for a corporation. I work for my patients. So at Brown and Toland, what we represent and what we're really striving to grow into to help preserve that private practice model over time is how do we allow physicians to still practice in that way where you can maintain that physician-patient relationship that we all grew up with, yet take away some of the hassles that they have to deal with. Are their staff going to show up to work? Employee benefits, insurance coverage, the technology, the practice management side. So while Brown and Toland in the past, at one point in time, was 100% independently contracted physicians, they all work for themselves and they contract with us. We've been starting to transform into that realm and go down further into where we can create an employed option for physicians. You can come to us and get exactly what you get from Kaiser, from a hospital system. We'll take care of those hassles for you. And so we've actually been on that path now of creating that employed model, the clinic model, where, if that's how physicians want to practice, but they don't want to be controlled by, Kaiser making the decisions, or hospitals looking, who are really focused on what they need and the referrals that they need into their own particular facilities. There's a place where you can come and you can practice that way, but you can also work for any health plan and admit to any hospital that we have contracted. The in-between model, which you see on the slide is called hybrid, is a really important one. We view an in-between stage. There's the physicians who are fully independent, and there's physicians who just really want to be fully employed and not deal with anything. There's a lot of physicians and a lot of opportunity in between, which we've been calling hybrid, and yes, we need to come up with a much more exciting name. But in the meantime, as we're building it, we've been calling it a hybrid, where that physician can really practice as if they're independent and still make their own clinical decisions, but we can take care of all those hassles, kind of through practice operations and helping them on the back end of their practice. And it's really a nice in-between model for physicians. It also allows physicians to go back and forth in between these models. If you think about the stage of a physician's career, typically when physicians first come out of residency and medical school, they need to build their practice. So it would be great to be in a practice where there are other doctors, more seasoned physicians, but then maybe they do get to the point where they want to, hang up their own shingle and become independent. We have a lot of physicians who are, maybe 5-10 years from retirement and would like to maybe start winding down a little bit. What a perfect opportunity to pair those younger physicians who are learning with the more seasoned physicians who are looking to wind down. They learn from them, and then you also have a perfect path for those patients to have a new physician once the retiring one leaves practice. So we actually have been putting this model in place, and it's going very, very well. That hybrid in-between model in particular is one that is proving to be a really good transition for physicians who kind of know they really need to be employed and they see the writing on the wall, but they're not ready to do it, right off the bat. So this has been a really exciting transition that we're on to create this, and it's important to us, and it's important to a CalPERS or to our health plan partners because physicians really are struggling to survive in their practices, and if we're not paying attention to them as well, we really do have an issue in terms of having care available to employees and patients. I talked about some of this already, and I think there's been a lot of conversation about market competition. And when I talked about the fact that we can be agile because we work with all health plan products, we work with we have different variations of practice models that we're really in a place where we can work with folks in any way. An area that I know is near and dear to Kathy's heart and to all of yours is what's the quality, what are the outcomes, what is it that why do we want to work with organizations that are trying to coordinate and consolidate care? What is it that you do that we do for you that's different than if you were working just with physicians directly, or how do we compete with Kaiser and others? And Brown and Tolan has been in the managed care arena for obviously, as I was saying, for over 25 years at this point, and we really are experts in terms of managing P4P programs, HEDIS measures, STARS. These are things that are just embedded into the fabric of our organization. We have put, as the market changes and, healthcare costs increase, we're able to focus in on specific areas, even at the employer level. What is it that you're focused with? A lot of times, we've noticed through the years, through trends, healthcare employer groups of healthcare employees tend to be high utilizers of healthcare because they're in the system. So we're able to actually use that data and work with health plans and employers, down to that specific level of, what are those quality outcomes and measures that you're looking for. And a lot of emphasis these days has really gone into transitions of care and disease management programs, which used to be so specific to, there's a diabetes program, there's an asthma program, and really where a lot of effort has gone into now is really complex care. There are so many patients with complex needs and multiple comorbidities, and so a lot of effort specifically put into how to manage and help navigate that care and ensure that the quality outcomes are where they need to be. Just as an example, this is a small one, but we tend to always focus on pharmaceutical because it's so high cost. But when you really think about having a physician-driven partner and what they can do for you, you can actually really hone in to some very specific things that have a meaningful impact. And just to show one very simple case study example on ophthalmology, just working with our doctors, getting them on board with a new program to change which drug they administer for one particular disease state. $400,000 savings in 1 year, just based on which drug they picked. 80% adoption, not even controversial. By helping them understand the difference in the cost and that the quality outcome is the same, having that physician-to-physician interaction and physician-driven protocols can actually really add up. This is just one drug and one specialty, and you think about what we can do when we pull the whole system together and do things like this. It does in fact have quite a staggering impact on cost. IHA, I wanted to talk about this for a minute. Hopefully many of you are familiar with IHA, Integrated Healthcare Association. Three of us sitting at the table are actually on the board. All four, I'm sorry, Barry, I'm sorry. All four of us actually sit on the board of IHA, which is an organization specifically around quality and outcomes data. And one of the newer studies that has come out of it, based on all the data of all these leading organizations, hospital systems, medical groups, with all of their data coming in, is that the HMO world, this managed care world, actually really does make a difference. There was a 14% difference in the quality outcomes from HMO compared to PPO across 10 different measures. So it goes to show that we're on the right track. And to the points made earlier, I think this transformation of healthcare has been going on for a very long time and not really getting the movement that we all want to see. But we're in the right direction. If we're paying attention to those quality metrics and the cost savings, how can we get to that balance between the benefits of what feels like a restrictive product in the realm of a less restrictive product feeling? And it's really helpful to see these numbers start coming together and telling the story that we in California as providers have been trying to talk about and do for a long time. Managing the total cost of care is obviously critical. And this is where, as a provider group, taking care of all of the patients, we're able to pull together all of the data, really at an actuarial level, and hone in on that to get to direct patient outcomes, everything from immunization registries to pharmacy data to lab and cost of care. So when we look at managing the total cost of care on behalf of a health plan or an employer group, it's critical that we really have all of this data and information, and it can actually lead to data-driven decisions and guidance to our physicians and patients on the right way to go. Population health, obviously a buzzword these days, and most healthcare organizations at this point have full departments called population health, where you're really looking at how do you actually get the value? How do we make sure that patients and employers are getting the value that they need out of the system? And I think Barry's going to talk about this quite a bit in his next presentation. So hopefully that helps just to give a perspective. We really do, we are one piece of the healthcare industry, being on the provider side. But when you think about how decisions are getting made in healthcare, it's really the physician who's driving where that patient goes, whether they need to go to a surgeon, whether they need to be admitted to a hospital, what drug they need. When you really stop and think about the role that physicians play, they're really kind of at the center, because they're the ones directing the rest of the care that patient needs to others. And so preserving the model of physicians to remain competitive and allow physicians to have a way to practice that meets the needs of this rigorous economic state that we're in healthcare is really critical. And I think organizations like ours, in partnership with CalPERS and other employers, are really trying to think long term on what we can do to stay ahead of that curve and make sure that we can meet everybody's needs. And with that, I'm going to hand it over to Barry.
Thank you, Kelly. I must also say it's a privilege to be before you today. Although I will say it's a little daunting to be on a panel that includes two luminary health economists. I feel like the fellow that showed up to a sword fight carrying a toothpick, but I will do my best. Memorial Care Health System, this first slide is just to give you a little orientation to our health system before I dive into some of the outcomes that we've been able to achieve. Our health system dates back well over 110 years. But it's in the last 7 to 8 years did we decide to truly transform ourselves into an integrated delivery system. And so one of the unique aspects, I think, of our health system that allows us to drive some of the outcomes that I'm going to share with you is seen in this map. We have 4 acute care hospitals in southern LA County and throughout Orange County, but 200 sites of care. The vast majority of those are ambulatory sites or physician sites, all off the hospital license, which is a point I'm going to amplify in just a moment. We do have what I like to characterize as a pluralistic model for our partnerships with physicians. We have a large division that allows us to employ physicians, as Kelly had referenced. We also have a fully integrated and aligned IPA for physicians that want to maintain an independent practice, but be associated with an IPA and a health system to provide all the infrastructure to deal with labor laws and MACRA and all those issues, purchasing power, that type of thing that frankly is driving a lot of physicians crazy. In the case of our ambulatory sites, we've chosen to partner with people that I like to say do it for a living. Our ambulatory surgery centers are in a partnership with SCA, which is an Optum company, and we have an exclusive relationship with them. Our imaging centers are partnered with RadNet, which is the nation's largest ambulatory imaging provider, and our dialysis centers, which are both clinic-based and home-based dialysis, are in a partnership with Fresenius. And I anticipate us continuing to expand this ambulatory division because we have evidence now how it's enabling us to drive value in healthcare, drive down the cost of care while maintaining quality and, in fact, enhancing access. This is just a quick snapshot and just 1 or 2 little statistics on each of the value-based products that Memorial Care participates in. We believe we have more value-based products than at least any Southern California health system in that we're playing in each one of these. And you're familiar, I think, with at least the first one, Vivity. CalPERS was one of the first employers to sign up with Vivity when it was just beginning a number of years ago. And you can see in the blue just one of the statistics I shared that working together with those other health systems and with, in this case, Anthem, allowed us to drive down the C-section rate collectively from 34% to 24%. Our partnership with Aetna, we have an ACO with Aetna that's actually in two product models. One is an attributed model, and I suspect you're familiar with the differentiation between attributed models and designated models. They also have a designated or product model, and we are outperforming the market trend for Aetna year over year by 5%. We also have a similar partnership with Anthem. It's an attributed model only, but I believe Anthem is moving down the path of developing a designated model where the individual selects to be in that narrow network, and there's a much tighter relationship and series of communications with the member and the provider system, which I think is the preferable model. We also have what was, when it began, California's first direct-to-employer model, where a large employer contracted directly with our health system with a health plan in the background. In this case, it's in another state, doing their claims administration. And you can see here we've had some rather significant success. This is an ACO model, but it's one that has with it considerably more financial risk. And we're able to, in the first year, reduce the cost of care from the baseline year by 4%. And I just received the second year statistics, and it went down 17% year over year reduction in total cost of care. And on pharma in particular, we've talked a lot about pharma today, even though this particular employer has for years used a PBM to help manage pharmacy costs. In our first year, we were able to drop their pharmacy expense by 25%. Their non-ACO employees that aren't in our model, it increased by 8 or 9%. So you can see a rather significant delta in pharmacy spend. We also like to play in a lot of the government experiments, if you will, or programs or plans that are trying to drive value in healthcare. We are participants in the bundled payment initiative and had great success there. We found that our physicians really like to play in that space and frankly be rewarded for savings that they help achieve. And this was a legal way to do it, because otherwise any reward from a health system to physicians to lower the cost of care, to save money, sharing those savings with the doctors, is a violation of federal law because of the Stark regulations, which, as you likely know, are under review for, I hope, significant change here coming up shortly. And then finally, just worth pointing out, we were a next-gen ACO, a Medicare participant. We were in that for 2 years. And you can see that according to a publication that came out just in the last couple of months by the National Opinion Research Center from the University of Chicago, we demonstrated we saved the federal government in 2016 $12.6 million. If I were able to have time showing the metrics and measures that they had attached to the next-gen ACO, our health system was either the best of the pool of 40 or so ACOs or in the top decile. However, we ended up owing the federal government over $5 million because of quirks in the way that product is designed. And we attempted to educate CMS to make change, which turned out to be quite difficult. And so in the face of no change, having that kind of performance, we decided we can spend our time elsewhere. So we opted out. I'm really sorry to say, but we opted out of the next-gen ACO last year. This just next couple of slides will show, I think, some of the outcomes that can be achieved in various forms of ACOs. I'm a big fan of the ACO. I'm a big fan of HMO as well. Most ACOs are on the back of a PPO product. And you can see here on some of the things that the employers or the payors want: drive down inpatient utilization. And here I am, primarily a health system where we started, talking about driving away business from my acute care beds. But we know that's the right thing to do, and it allows us to perform very well under these value-based products. ER visits down by 17% in these products. Here in imaging utilization, this is not the cost of imaging, but rather we look at high-cost imaging, MRI, CT, PET scans, and the like. And by working with our radiologists and our physicians, we're driving those down, either by choosing a different imaging modality that accomplishes the same clinical outcome that's less expensive, or by moving them to a different site of care. Or avoiding it entirely because our EMR system allows us to know that this patient had a similar study within a reasonable time frame, and we needn't duplicate that study. This is the cost of, just the overall cost of care. This is, I mentioned earlier, in our largest direct-to-employer contract with a large employer in Southern California. The first year reduction over the baseline was 4%, the second year 17%. And again, these have significant risks. So as Kelly indicated, it takes a larger infrastructure, either a very large physician organization or a health system, to have the infrastructure and the financial backstop to allow you to play in these areas. But when you can, and you align the incentives of the provider system, the payor, the employer or health plan, and include the employee, you can really drive significant savings while improving quality, improving access, and patient satisfaction. This is just a graphic that shows what I mentioned earlier. The lines represent the Vivity decreased cesarean section rate, as well as the cesarean section rate decrease with our direct-to-employer plan. Again, this is something that when we focused on it, we can drive down those unnecessary cesarean sections. So a question has been presented in the past when I've shared some of these figures, because we are a health system that grew through consolidation, mergers, acquisitions, and integration. And those seem to be, unfortunately, in some circles, bad words today, because they're sometimes linked to raising prices. And we're demonstrating we're not doing that. And so what are the elements of our system that allow us to accomplish these goals? And it comes in a few buckets, and I'll share those, and appreciate that you have these slides, so I'll zip through them rather quickly. But it takes not an insignificant infrastructure. Data is key. And we have to have, as you see, those various data inputs to allow us to truly manage the cost of care, as well as analytics. And that's an area that we continue to work on in our health system and refine and try to perfect our ability to do true population health analytics. And we also work with partners, because our health system in many cases doesn't cover a geography that matches perfectly with the network we're trying to put together. For example, in our large direct-to-employer plan, we brought in a couple of other like-minded, value-focused provider systems who were willing to take risk so we could cover the geography adequately for that particular employer population. The care management infrastructure, Kelly touched upon that, I think in many respects, but we really focus on the high-risk patient. You know very well that it's a very small percentage of patients that spend a very high amount of the dollars in healthcare, and so focusing on them with a multidisciplinary model allows us to really drive the cost down and provide them much better care and improve their health, I think, more significantly. We are working in all the various forms of virtual case conferences, the telehealth, telebehavioral health as well. This is an area that, not without controversy. In fact, I just read this morning that a number of hospitals throughout the country have filed a suit against CMS for moving towards site-neutral payment, where they refuse to pay differing amounts for the same procedure, sometimes by the same provider on the same patient, depending upon what site of care it is in. And as you may well know, that outpatient procedures can be done in two locations, either a hospital, what's called an HOPD, a hospital outpatient department, hospital licensed entity, or a community-based entity. And those dots on the map that you saw are ambulatory surgery centers, our imaging centers, our dialysis centers are all the non-HOPD variety, so they're community-based, market-priced. And the delta in price can be significant. For Medicare, before site-neutral payments began to go into effect, for the same procedure on the same patient, the delta was 125 to 150%. On the commercial side, it's 200%, in some cases 400% delta for the exact same procedure. And so we made a decision in our health system that it wasn't the right thing to do, it wasn't the value thing to do, it was the long-term play to not bring business into our HOPDs, our hospital license centers, but develop this ambulatory network that we could deliver closer to home and at a more competitive price. And you can see that we haven't cannibalized ourselves because we found out fortuitously that when we began to partner with physicians in these ambulatory sites, they began bringing more of their business into our hospitals as well. And so we didn't, eat ourselves alive. Now, I will say, to be quite candid with you, that it would have been far more financially accretive to our health system not to follow this strategy. We could have made millions of dollars more by driving that business into the hospital outpatient departments. But we chose not to do that. And for many, that's a very difficult choice to make. And then I think finally, engaging the patients is key. That's why I made the reference earlier about vastly preferring the designated model of an ACO, where the patient actually knows they're in your network, they select your network, you have more access to communicate with them, educate with them, direct them to the right location of care. And you can see the variety of ways we're using. Some of these are some startup companies in healthcare that we've supported and are now rolling out to allow us to communicate more effectively with the patients and coach them in their care along the way. So with that, I believe I will hand it back to Dr. Robinson.
So now is the time for President Jones and the rest of the board to ask questions or make comments of your interests on how we can help you in these complex matters.
Okay, thank you. Mrs. Taylor.
Because I sit right here. So I had a couple of questions, and I really appreciate the panel here. I'm still at a loss. I think, Dr. Arbuckle, your overall plan is great, and you said something about that you didn't have to do that, and you could have made a whole lot more money, and you didn't. But and it was through the. You did a lot of mergers and acquisitions, and then you put together this infrastructure that was really helpful for you to be able to drive the prices down. How do we ask for the better angels of other, mergers and acquisitions that have occurred so that maybe they would be willing to help bring these prices down? Or what is your opinion on that?
Well, I think there's probably at least two answers. One is more market-based. I'm hopeful that as more of the business in a given provider network becomes at risk or value-based, they'll begin to move in that direction because you truly can perform better. Right now, the proverbial, 1 foot on the dock, 1 foot in the canoe is a very uncomfortable place to be. And even in our health system, I would gather that maybe 40% of my acute care revenue still comes in some fee-for-service manner. It's only about 10% on my physician division, and about 70% is kind of fee-for-service in my ambulatory division. But in spite of that, we said we're going to treat everyone as if they're in a value-based product. Now that, again, is, as I mentioned, is not the best financial model for me. So we have the balance sheet to be able to sustain that period of time as the system evolves. I think also both policies from the health plans as well as from the federal government. And in the example of the ambulatory care, the federal government is moving down the path of site-neutral payments. We don't care where you get the care for ambulatory, we're going to pay the same rate. Whereas the health plans are taking a slightly different approach. They're beginning to, not as quickly as I would have imagined, but beginning to put in some clinical criteria. They recognize, which I think is the fair argument, is it reasonable that a hospital-based ambulatory procedure should cost more than one done in the community? And the answer is actually yes, because it's under the hospital license, it has all of the infrastructure, the regulation that comes with that, and they tend many times to get sicker, more complex patients. Now, not all of them are, and that's part of the problem. So there's a reason for that, but I think the key and what the health plans I think have really focused on is when there's a clinical criteria for the patient to be there, then it's appropriate and we'll pay that higher amount. Otherwise, we're not. Let me give you a quick example. My mother had knee surgery a year ago.
Me too.
My mother's almost 80. She has, maybe some comorbidities. It's probably reasonable that surgery, if it's not done in an inpatient facility, should be done in proximity to all the resources of an acute care hospital. However, if my 27-year-old son blew out his knee this weekend, he could easily have one of his surgery in one of our ambulatory surgery centers. We do them in and out in one day at 1/3 the cost. So that's the difference, and so health plans are putting into place policies where they'll allow cases to be done in the HOPD and some where they don't. My frustration is a lot of hospitals and health systems are still driving that business into the HOPD irrespective of the clinical need, maybe because that's all they have. They may not have an ambulatory network, but that's raising the cost of care. In fact, Dr. Robinson published that in JEM, I think in 2015, that showed that many times it can increase the cost of care when that integration occurs between hospitals and physicians, and it's heavily driven by that ambulatory care.
I'd like to actually make a little comment on that myself, if I may. And that is from a purchaser perspective, to encourage provider organizations to behave the way that Barry's described, what they want really in exchange for cost moderation is more patients. That's the normal business reward. And one of the perversions of our system of the health plans is that they will contract in the same market with a high-price provider and a low-price provider, and the low-price provider doesn't get more business just for being low-priced. And so it's almost like, why am I doing this? Barry basically said that, and he's got a long-term view, and there's a variety of things. But it's an incentive, actually, to charge more. And so you already are partially correctly down the road with reference pricing as one approach to this, but even within the HMO product, if there's multiple in the same market, provider organizations, and they're charging the health plan different rates, the one that's charging the lower rate, unless there's some reason otherwise, should get more business. And so you should think about how to make that happen, and some of the initiatives that Kathy and the staff have done give you more visibility, have helped that.
And I had one last real quick question, which is, imaging has been around forever, all of these types of imaging. So just like our TVs and our phones and everything, the cost comes down. Why has imaging cost not come down? That just drives me crazy. I mean, it's a technology, right? And it would seem to me the price would decline, and I don't know the answer to that, but it's a question I'm throwing out there.
Is that a good health economist question?
Well, let me put it this way. If I were a provider of imaging in this world, why would I reduce my price? What do I get? What are you giving me for that? Okay. Now, the reality is that within any given market, there's a huge variation in the price charged for the same, for MRI, for CT, and in your in the reference pricing world on the PPO side, you can really see that and develop benefit designs. But it really comes back to this issue: unless there's a market reward for lower price, give me a break. Providers have need for revenue, just like everybody has need for revenue, and they will take advantage of a purchaser that's not being savvy.
Okay, Mr. LaFasa?
Thank you, Mr. President. Thank you very much for your presentations. There's a lot to chew on, and I won't attempt to recharacterize it. There's some things that I've been working on related to lots of innovations, of technological innovations and consumer products that get written a lot about in other spaces. And I wanted to ask you about them because sometimes when I read about them, they seem to relate on the back end to some of these vertical consolidations happening between PBMs and insurers and such. For example, there's two things I wanted to ask about. The first one, for example, I've been reading this technological visionary gentleman named Eric Topol, who writes all these books about how applications and stuff on your iPhone and all these consumer tools are going to shift the power balance between physician and patient. But when I read in other places about these things, I get the sense that a lot of these consumer tools are supported on the back end again by some of these big changes in the marketplace that we read on the business page. I got at least one acknowledgement nod as I'm saying this all. If I'm barking up the right tree, can you connect these dots for me or for us?
I'll touch upon a little bit of that. I'm familiar with Dr. Topol's work. We're big in our health system. We're big believers in investing in new technologies in healthcare. In fact, we have an entire division of the company that operates like a private equity investment company. and then we help them develop the product, refine the product, know how to sell the product to a health system. We're only interested in ones that we believe can generate value, either reduce costs or improve quality or both. We're not necessarily looking for the big liquidation event 5 years later, although they're nice when they come. I think it's a bit of a mixed bag. I mean, the technology is greatly helping us deliver care, I think, more cost effectively, or has the potential to. There's also some of those technologies that, and I hate to characterize it this way, are more cute than they are effective. The EKG on the Apple Watch, I mean, it's neat. It'd be kind of fun. But my great concern is we're going to have a situation where there is significant overdiagnosis. People will throw something that's quite normal, they'll call their physician, they'll have to go through a test, and wholly unnecessarily. So there's got to be a balance between the introduction of new technology and a whole other area that is just beginning to get some traction in the U.S. and worldwide, and that's called overdiagnosis and overtreatment. That we're in some cases doing too much to too many people, finding things that would have never impacted them in one way in their life, yet once we find them, by golly, we've got to treat them. And sometimes when we treat them, we do harm. So there's a balance there. So I think that's why there's this kind of schizophrenia, if you will.
Appreciate that very much. And I was going to direct my second question to you also, Dr. Arbuckle. I'm not sure. I see blank faces from the other group, so I'll waive the opportunity to comment. You talked a lot about direct-to-employer relationships, and again, on all this stuff I read in other spaces like the Amazon, Berkshire Hathaway, J.P. Morgan alliance that was a big deal a year or so ago. One of the buzzwords is disintermediation, fancy word for eliminate the middle person, which seems to, again, rely on pushing out insurance companies and go into these direct-to-employer relationships. But are these the same things that you were talking about in terms of the direct-to-employer relationships in your slides? And again, I'm, for the benefit of the group, trying to connect my technological questions to the consolidation issues we're all talking about. Again, you alluded to, insurance administrators on the back end in other states, and you talked about big data. Are you doing the same thing as those other guys, just with less hype?
Well, that was what I was referring to in the direct-to-employer. It doesn't certainly eliminate the health plan, because there's a lot that the health plan does that they can do at scale far better than I could ever do it. And it takes, I think, a unique set of characteristics of an employer for it to make sense to do a direct contract with either a health system or some provider network that's been put together. You have to have a fairly significant concentration of employees in one place. And so the Boeings, the Disneys, the Intels, the Qualcomms, the Ciscos, maybe even J.P. Morgan and whatnot, I'm not sure. So those are just yet another model. And there's probably also some benefit that as a self-insured employer, they don't pay the health plan tax, so there's some benefit there. They can be more directly involved in product design, which some of these larger employers are extraordinarily sophisticated in dictating product design. And so that's why I think we're seeing some of the better results in those.
And I can add on to that a little bit. Agree with everything that Barry said, and Brown & Toland's been doing that as well. You do still end up finding a role with the health plans typically, even in direct-to-employer, for a couple of reasons. One is typically they are the back-end administrator, like a TPA, a third-party administrator. So even the self-insured still need someone to process those claims and do the operations if you don't have that operational ability the way a Memorial Care or a Brown & Toland does, or others. The other is a really big one, which is the pricing. When Barry just talked about you need a really large concentration of employees in one place, typically what you find is the employer is still needing access to at least one health plan for the out-of-network, for all the care that ends up at other providers. So there ends up still being a role needed in almost every case for a health plan relationship, so that you have the broader access, that safety net of providers available outside of that core geography of the employer. But there's still, even though there's still a role typically for the health plan, it still does achieve a lot of cost savings, because that role that they're playing as that intermediary is much, much smaller than it is as directly through an HMO or a PPO product design. So I do think I think that's partially why we're seeing so much attention going into that direct to employer and self-insured market right now. That trend is definitely continuing to grow.
Appreciate it. Thank you, Mr. President.
Okay, thank you. Mr. Miller? Turn yours off, Alan.
Oh, there we go. I thank you very much. I have kind of two things. One, and I've kind of been observing this for a long time, and I think back to my hometown, which you'll probably guess at some point, if not from my relatively neutral accent, but the context is when I was working in healthcare in the late 70s, early 80s, there was no consolidation. There was so much overlap, and especially the university medical centers. I mean, everybody had to have this new NMR thing, and so there were like 6 of them within 2 miles. And then gradually, you started to see a little bit of consolidation, but then it accelerated to the point where it is almost total consolidation within the metro area, and there is one smaller group of hospitals and providers, and it got to the point where the University Medical Center run conglomerate actually took on the big insurer to the point of saying, if you have insurance through the only big insurer left, you can't come to our hospitals except through the emergency room door. And it's really been kind of an object lesson for everybody else of, holy cow, in a matter of 20 years, you can have this situation where the physicians are just feeling like they are stranded. They're just totally a pawn in this game between these behemoths. And I look at it and I wonder, for someone like CalPERS, it's a little different because we have such reach. We have local government and state government folks, so it's not just regional battles going to overcome us. But when we talk about competition, I struggle with, the competition that we see as competition here for us to choose and work with folks, and versus what our members see. Our members see it really differently. They see it as, a lot of them are saying, well, geez, I don't have choices. I've either got to go, I either don't have an HMO, or I've got this one PPO that I can afford, or they're not seeing the kind of choices that they used to see, where they had, a number of different providers in each of these categories to choose from. So from your perspective, how do we look at competition in order to balance the kind of idea that our members have about what they want to see in the way of choice versus us engendering kind of our posture toward a marketplace where we create enough competition to have that concept of managed competition work, but that potential mismatch between what our members see as competition and what we're trying to do to deliver value to them.
Well, I am not totally sure where you were going on that, in the sense of a lot of this discussion has been about fostering competition among organized systems of care. And that's the usual managed competition paradigm, and that's what CalPERS has really been about. Now, down at the individual patient level, it may be that what they want is more choice among physician practices within each specialty, within their regional market, and that a lot of it depends on the supply of providers. It also depends on the extent to which the consumer really is willing and wants a price-conscious choice. See, many consumers say choice means I can go to whichever doctor I want, whereas from the purchaser perspective, it's like, well, what if those doctors charge different prices? Are you willing to pay the difference? And the usual consumer answer is no, healthcare is a right. You know, I mean, that's the, and so it's a tricky balance you have to navigate. How much are we going to expect the patient to pay the delta, the difference, if they choose the more expensive? Because sometimes they choose it for good reasons. They are sicker. They need to go to the more expensive place. And other times it's just, it happens to be closer to where I live, or it's more convenient, or my mom went there, or something of that nature. And you all are have to be responsive to the opinions of your membership, of the workers and the other groups that you represent. And I appreciate that a lot of Americans are really not on board with the concept of cost-conscious choice. They love cost-unconscious choice. That's what they actually like. And so there's no easy solution to that. One thing I do think, though, that we can all agree on is that the choices need to be simpler. I actually believe that one of the biggest problems facing the healthcare system is it has gotten so complex that to make the notion that even we're all experts, right? Everybody in this room is a healthcare expert. And we are mystified at times about why is this happening, and what did that cost, and what's the true cost, and and all that, what's quality, and it's very confusing, especially for the sick patient. And so one of the things we need to keep in, I think our goals are quality, cost, access, and simplicity. Let's not let the economists design things that are so efficient but so complex no one can understand.
Yeah, I like that.
Okay.
I want to add, one of the things I didn't get to really speak to is that as our plans ebb and flow with their geographic areas under DMHC, really what we have learned is that we need to be closer to the Kellys of the world, so that if a plan exits an area, I can go to a Kelly and say, okay, I have these other 3 plans. Please make sure your patients know that these are their choices, which is exactly what we did this last go round. So the way we have managed our competition is such that it goes to sort of the crucible around which claims are processed, yes, but it goes one step deeper, and that is we want our members to keep their doctors. And if a plan exits an area, for whatever business reason, we need other plans to be in that area with that provider overlap so that that patient keeps their doctor. And that's what we have learned, and that's part of sort of that 3-dimensional look at, you know, plan competition, provider competition, but also market overlap so that choice remains for the patients and the members.
And you know, there's an interesting parallel to your question and the one earlier about radiology. When you think about the competition, I think what you're saying, like even if you look at Northern California versus Southern California, the competition has shrunk more in Northern California than Southern California so far. And when you look at some of those systems who are not doing what Barry is by Barry's creating the outpatient, the inpatient, he's got the entire spectrum of care so that the patient can be treated in the right setting at the right time based on their need. That's rare to find that it's that well developed, and that's what we need more of. But when you look at your question about competition, I think you start to see that there's some healthy pushback. Like look right now with the Attorney General pushing back on Sutter. Sutter has consolidated and taken on so much market share that now they're being challenged about it. You look at some of the large medical groups around the country and in Southern California who have come together that now they're starting to be the pushback. Well, you know, they're starting to get just that little bit too strong to where the radiology rates, now all of a sudden the only one available is $700 compared to the RadNet for $150. And I think that there's just an interesting correlation to your question and the pricing. And to Jamie's point earlier, that if we don't help sustain, as long as they're high quality still, if you don't help sustain those smaller players so that they can survive, we are in fact going to end up seeing this market, whether it's a health plan or a hospital system or even a medical group, consolidate to the point where the pricing has actually gone in the wrong direction at this point. So it's all about making sure that we maintain competition in all of those realms to keep the pricing and the quality in the right place.
I have a story that you might be amused by. When I first came to Stanford, because of previous experience with prepaid group practice, I came to Kaiser Permanente and said I'd like to form a consulting relationship with you. This is back in 1973. And a few days later, I was invited by the doctors in San Mateo County, up north of us, to come and talk about, they're considering whether to form an IPA. So I went up there and I gave them a big pep talk about, you're going to lose all your patients to Kaiser. You really need to get your act together, cut your costs, and offer people a comparable deal. And the next morning, it turned out there was a health plan, Kaiser health plan representative in the audience. And she went back and said at the headquarters, what's our consultant doing stirring up competition? So the phone call was from Jim Vose, then the CEO of Kaiser Permanente. He said, Alan, I wanted you to hear this from me first. What my message to you is keep it up, do more, do better. Encourage them to form an IPA and compete with us. I could do so much better a job of managing this institution if I just could point to some competition. And so I just think, even they want to see some strong competitors. And that's a real challenge for CalPERS.
And then just finally, I'm sometimes the crazy ideas guy. You may have heard me mention a world without PBMs earlier, but in the crazy ideas department, is there a role for CalPERS in, we see these community hospitals, sometimes not so strong, sometimes stronger, but we see them either being integrated or into a bigger system, or we see them where it's kind of blinking out. And would there be, in your view, any kind of role for us to, step in and try to keep a community hospital and maybe some associated community-based outpatient clinics or something from blinking out, particularly if, what's left is the sole FQHC in the whole area now, and we'll be really reaping that benefit and changing that marketplace.
Given CalPERS' breadth and the volume that CalPERS has, I think there well could be. Some of those freestanding community hospitals don't even have contracts with most of the health plans, because if they're not in a market unto themselves, there's really not a driving need to have them available, because and if they're offered rates, they may be quite low and they're unsustainable. So many of them opt just to go without, and just business comes to the ER, and it is what it is. I can imagine, and I have not thought at all about this since 30 seconds ago when you asked the question, but could in some geographies CalPERS contract directly with that small community hospital or a network? They'd have to have a little, some physicians that were affiliated with them in some manner or form, maybe some ambulatory sites, in kind of a direct relationship. And I can imagine it being an upside ACO, because they probably, as a small community player, don't have the balance sheet to sustain too much risk, even though we know risk can drive greater value, but maybe an upside ACO to allow them to survive. It is one of the concerns, I think, in some of the markets, that we're going to lose more of these hospitals, and it's going to create more of a problem for us.
Yeah, because I think of an example where I think if, X years ago, CalPERS, again, crazy idea guy, would have actually stepped in and bought a community hospital that was teetering on being gone. Other people did step in and brought it back, and Valley Care is doing phenomenally well now. But it took bringing in a significant investment, a management team focused on performance excellence and turning it around. And so, that's kind of what prompted my question. Thank you.
Okay, thank you.
So we have promised Kathy and the panel to wrap this up at 3. So maybe President, you can
Yes,
sort of bring
I
us
was going to ask, let the members know that we have 3 more requests for questions, and I'm going to cut it off after that. And we have Ms. Hollinger, and then Mr. Rubalcaba, and then Mr. Cobb. And if you could limit your number of questions, I'd appreciate it. Okay.
Yeah, questions. I'll be quick. I know when you were talking about the savings from C-sections and reducing that, a lot of reasons doctors do C-sections. What's the correlation between these cost savings and malpractice? And and two, are you familiar with Regina Hersinger out of the Harvard Business School? What do you think about giving the consumers the money and that creating the competition that the money's going to the wrong hands in a consumer-driven healthcare?
This is where we might, the
You know what?
possibility of an arm wrestling match up here on the panel. We may or may not
Okay.
differ on this, in this regard. I may be incorrect. To be quite honest with you, while handing more of the money to consumers fits in almost every other industry, empowering them to make their own decision,
Right.
and it can drive down costs. It hasn't been shown to work so well in healthcare. Maybe because it's too complicated, maybe because it's too convoluted, maybe because there's not enough transparency. But if I'm correct, and our two health economists are more savvy with these studies than I might be, some of the data that I've seen suggests that it is indeed true when you hand the consumers a high-deductible health plan, which again I'm not a real big fan of.
Well, I'm not necessarily saying, because I'm not an advocate of that.
Okay.
Okay, I'm actually an advocate of giving them the money and then letting them decide. So, you know, it's a little bit different.
The problem is that
Yeah.
competition hasn't been tried enough. Like 60% of employed insured in this country are under self-insured arrangements where the employers sponsor an open-ended fee-for-service plan. And so the CalPERS and California Choice and the federal employees are unique and quite unusual. And I think the problem is we haven't been able to spread the idea of competing choices to enough people to make the market work. There are too many people in the cost unconscious mode.
Got it.
In fact, you know, something I wish we could do is consider, could CalPERS, which serves hundreds of local government agencies, could they be opened to private employers who would like to try the competition model?
Right.
Somehow we just need to get this idea of informed cost-conscious choice instead of being a small minority, getting it to be the
You need scale.
the dominant mode.
Rubalcaba?
Thank you, Mr. President. I really appreciate the panel presentation. I like how it was framed about bewilderment. And so that's what my question is. And one of the questions that was posed is how many, you know, about health plan competition, how many health plans do we need on our menu? And one of the questions that always bewildered me is that, following to Mr. Miller said, members sometimes choose based on advertising, right? They don't pick a medical group, they pick an insurance company, even though the same insurance company may contract with all four insurance companies may contract with the same medical group. Yet they have different capitation rates with that medical group. So would things change if it was somehow the capitation information was public and somehow only the best plan with the best, I mean, I'm not sure how to win it, but you know, we support value networks or narrow networks, whatever, but not everybody's going to be in it. So why hasn't there been a drop of the medical groups who are not efficient or not having the best value for or best outcomes? So why would all that efficiency still continue to exist when you have medical groups trying to negotiate the best rates for the medical groups in the hospitals?
Well, I think quite a number of health plans haven't made the grade and dropped out or encouraged to drop out. But the special thing about CalPERS is that the employees get an informed, cost-conscious choice, so they can consider convenience, location, practice style, and consider all these values and have a choice there also.
I think the dilemma is that the way you structured, your members have a cost-conscious choice of health plan, but the health plans, with the exception of Kaiser, contract with multiple different medical groups, and that level of is opaque to the member. It's too complicated, and they don't have a financial incentive in there, except for where you have some variant of reference pricing. So I actually think that's where you need to go, is somehow, in a simple way, make it clear and have an incentive so that they know, and really, it's got to be really simple, you know. Let me tell you how the Kaiser model really works. How does Kaiser really work for the consumer? Because consumers, if you're a Kaiser member and you're at a building and it says Kaiser Permanente, go in there. If it doesn't say Kaiser, don't go in there. That's it. That's it. That's what they can handle. That's what members can handle. So it's got to be really simple. It's got to be effective but simple.
If I could just follow up, just on that analogy about Kaiser, I raised that issue, and their competition will say, well, they're a super narrow network compared to our network. So that's why, but yet, you're right, people would pick, say, the hospital. I mean, I'll use Vivity. I mean, Vivity has some great hospitals, and people will pick based on the hospital, yet their medical, they may never have to go to the hospital. And hopefully they won't. Hopefully the preventive care of the medical group will take care of them. So that's what bewilders me, and I can appreciate Mr. Miller's thing about looking at it from the member's perspective, or what they call choice. You know, we have a lot of work to do, so I appreciate all the work CalPERS has done on you, Kathy, but.
And you can, you know, you can take a harder line with the health plans. I work for the University of California in Berkeley. Berkeley, the biggest provider of care in the Berkeley area is Sutter Health. The University of California has carved Sutter out of network. You cannot go, if you live and work in Berkeley, to the Berkeley-based hospitals, which are Sutter facilities. It's amazing. You can go to Kaiser down in Oakland, or you can go to John Muir out there in Walnut Creek, but you can't go to Sutter in Berkeley, or in Oakland, or in San Francisco, or it's out of network, basically. And that's because the university has been willing to say, there's enough other good providers, including UCSF, which is, of course, excellent because it's part of the university. And they've been willing to do that. So you can consider variance on that if you wish.
And I would just add and echo that it's really about the big driver to take this to where it needs to be is more transparency. There has to be cost transparency to the patient level about the choices that they're making.
Thank you.
Okay, Mr. Cobb.
Okay. All right, so this, and I really begged it to be the very end because, and make it short because Dr. Enthoven, we need to go. Okay. Thank you.
Thank you, Mr. President. This morning we had a panel that talked a lot about rural health care, which was one of the 3 areas that Dr. Robinson had concerns about. And almost all of the solutions that were shared by the panelists were limited to the Medi-Cal population. And, you know, as public employers, I represent the state employer, but the same is true of the locals. I mean, our employees are the ones who ensure public safety and keep the roads open, and we just can't decide to pull our people out just because there aren't enough doctors. And the numbers that they shared are showing that the doctors out there are aging out and retiring much faster than they're coming in. And what do we need to be doing collectively as a as a healthcare community to shore up the physicians in the rural areas, to keep them there and keep enough physicians there to serve our members without creating monopolies that just simply come back and leverage us for price.
Before you respond, we want to thank you, Dr. Enthoven. Okay, proceed.
I'll be right back.
My personal view, and you may have, is that the reason the doctors are dropping out of the rural areas is they don't have support systems for them. And so what they need is not just sort of money, nothing wrong with money, but support systems. And it would seem that if I were you and I was working with, let's say, a Brown and Tolan in the Bay Area, I might say, listen, I'm going to like you even better if you will take on
Are you going back with Jamie? or are you-
Mendocino County or whatever, and how can we make that work? How could your systems work in Mendocino?
Oh,
or whatever
really?
that relevant county is.
Yeah, I think a couple things. One is the infrastructure that Jamie's
right.
referring
Well,
to, and I think you
my
could
respects to both
partner
of them.
with
I think I've cited all
provider
three of
groups
you
or
in prior
systems to help
papers
provide
and,
some coverage in the
doctoral
area.
program dissertations
In some
and
cases,
things.
it's the infrastructure
yeah,
support
let me
that
go
there may
get
not be
Jamie
enough
out of there
business
so
in
you
that
guys can
particular
get on the
market
road.
to support building
See,
it, so
it's
you
doctor-
could get that
it's-
from
it's,
others. The actual
Fix
access to
and-
care. I do know in some areas, I know just in my Optum days, sometimes literally investing, when we were talking about investing in hospitals, investing in the physicians, if there's not enough volume to keep the care there, then it's honestly sometimes the care it just needs to be subsidized. The other option is to work with providers who can go up, on a recurring basis and provide coverage, but not necessarily work there full time every day or live there. But you could. I know some of our doctors do that. They actually go to some of the rural areas 2 days a week to provide care. So maybe partnering with a provider group or bringing in 1 or 2 key primary care physicians that CalPERS is subsidizing, which is frankly a small price to pay probably in the big scheme of things to make sure that there's access to care available on a regular basis.
Okay, well, thank you all. Your presentations will give us food for thought as we pursue our goals to improve the quality of care, contain costs, and improve patient outcomes for the members we serve. So join me in thanking the panel.
Thank you, guys.
So we will begin the next session as soon as we get recharged.
You moved pretty quick.